Hello, hello. Welcome, everybody. Welcome, Cali. So excited to have you back and to join us today as we continue our Ask the Experts series. Couple of announcements. As always, please make sure that you remember a couple of things from us. And then, of course, I want you to make sure you're tuning in to all of our upcoming events. So first announcement is that one of our lead advocates, Tom Smalley. Tom is incredible. Cali knows Tom and has worked with him a lot as he heads up our anxiety in athletes. He's going to be doing our Community Conversations live stream, which will be at 7 p.m. Eastern time next Tuesday. So please make sure you attend and watch. That will be incredible. Tom is awesome. And can you believe that the online 2022 Spanish conference, Teose, is this weekend. So if you haven't signed up, please make sure you go to IOCDF.org to learn more, to sign up, and make sure you tell friends, colleagues, or patients who are Spanish speaking and could benefit about this incredible resource. As always, you can go to IOCDF.org/peace of mind to submit questions, learn more, and to tell us what you want us to talk about, what you want to hear. That's really important to us, and it's how we kind of tailor what conversations and topics we're going to cover during these live streams. As always, if you're feeling unsafe or suicidal, we are not a crisis hotline. So we want you, if you're in the US, to call 811, which is the new suicide prevention line. Or, of course, you can call the 1-800 number, go to your local emergency room, or call 911 as well. If you're outside of the US, please follow your local resources for how to keep yourself safe. So I've already seen a couple people say hi. So hi, everyone. Thank you for joining. Please make sure you put questions and comments you want us to address in the pane on the right-hand side of your screen. So over there, and tell us what you want us to cover, questions you have, and we will absolutely cover it. And we are excited to have you here. As for those of you who attended last week, Cali was here. For those who haven't, I'll just do a brief introduction and let Cali say hi. But Cali Werner is an incredible OCD advocate, OCD clinician, and athlete as well. And Cali is someone who has shared her story, but also can share her perspective to move the needle with patients as she provides OCD treatment both to individuals and families. Cali is someone I've worked a long time with, and I have so much respect for her. And I'm just so excited that she can join this live stream as Chris is still out of town, to give her perspective, to give her thoughts, and for us to be able to answer questions in a way that we hope is educational and helpful for you all. So welcome, Cali. We're excited to have you again.
Thank you. Excited to be here.
So what we're going to do today, you guys, is we're going to start with live stream questions. Then we're going to go to our pre-submitted questions. Then we'll go back to live stream. So please make sure you put questions that you have along the way, and we will make sure we address them. Both Cali and I will answer them as we can. But Cali, I'm going to throw a couple to you. So we'll start with Ida at 1242. One of my most annoying compulsions is rereading. I reread when I felt I haven't reached a certain understanding or that I begin to have or had intrusive thoughts. How do I get better at efficiently reading?
So there's a lot of different ways you can do an exposure with rereading. One, if you feel it is almost impossible for you to not go back and look, you can start off small with moving a paper up the words as you go so that you're covering it. And then you're at least giving yourself a little bit more time to not automatically respond to that compulsion. It's always, with all of these exposures, it's about starting off small and moving forward. But really the core is leaning into, maybe I possibly missed some information, maybe I didn't, and kind of pushing forward through that. So baby steps along the way, but there's a few different strategies or things that you can do to help make that exposure less intense, like covering up with a piece of paper.
Yeah, and what I would want to say, Ida, that we talk a lot about is, are we also targeting the core fear, right? So while I would say the piece of paper or not rereading, that's the response prevention, right? So the exposure or trigger, sure, might be reading, and we engage in this response prevention, but also, are we targeting the core fear that you might have missed something, right? So what we don't want to do is just read, not reread, but kind of just like, oh, I'm just surviving through, and I still hope I understood everything, and I still hope I got it, because then you're going to continue to have this urge to reread. When really what you're saying is, how can I just read efficiently? How can I just enjoy reading, right? And it not feel like it's this feat or this like horrible or daunting task. And that's going to come from being able to do both. So choosing to read without rereading and accepting that uncertainty that I don't know for sure if I understood or absorbed every single piece of information, but I'm going to, go on the fact that it's good enough and move on. Because now we're not trying to do OCD exposures, but also still make sure things are okay and it's good and we did good enough, right? We're actually leaning into that fear. And the more we can accept the fear that like, yeah, like I read and I hope I understood, or, you know, I hope I figured out as much as I could or as much as I needed to, with kind of this like slow response, low anxiety type of statement where we're not like reacting of like, did I understand this? Did I get it all? And it's this urgent need. You will actually find that if you do that, and we're actually approaching the fear that exists at the bottom, the urge to reread will lessen as well. And that's important. Let's discuss a little bit. Your next question at 12:51 is, please also discuss late adult diagnosis. I've spent lots of time attempting higher education. How do I overcome grieving the potential life that I could have had? This is a great question. And I want to encourage you to watch some of the pre-recorded community conversations with Ethan. In particular, there's some about life after OCD. There's some about grieving, kind of the losses. And we actually have a group here at McLean Houston on grief and OCD, because we find this exact thing. Where it doesn't really matter what age somebody is diagnosed, treatment works, treatment can be successful. But what we know is that sometimes, depending on when we're diagnosed and when we get treatment, there is different levels of grief that we might have to go through, of being able to kind of process and understand the impact OCD had on our life and on being able to live and being able to do these things that are important to us. And so I'd want you to work with your clinician to really process that. What we don't want you to do is just suppress it and just say like, oh, I shouldn't have any grief and now I have treatment and I should just be able to move on. We want you to be able to process and acknowledge that, like, man, OCD really impacted these years of my life, and it had, it really might have taken some of these things away from me. And now that I've had treatment, I can live my life again and I can have so much more gratitude. You know, the thing I will say is like, I don't take little things like taking a shower, being able to get dressed quickly for granted because of my OCD. Now, do I wish that I never even had to think about it at all? Sure. But I also have new perspectives, right? And so can you have new perspectives? And now when you do these activities you previously couldn't have done, can you acknowledge all of the joy and being present that exists in that activity that otherwise might not be there? Last question from Ida is it 12, I guess. I'm seeing your times now. Sorry, Fran. It goes back and forth. So it's interesting. Please talk about overcoming the guilt and shame of not starting and avoiding something because of its uncertainty of good outcomes. The perfection of not starting, waiting to start, slow to start, etc. So Cali, can you talk a little bit about guilt and shame when OCD kind of impacts decisions?
Yeah, this comes up a lot. And I think we all have moments when we're struggling with OCD where we jump in and we do a compulsion, or we take the short-term way out of trying to get some instant relief. But what we do kind of forget or dismiss at times is that we learned from that experience. And when we learn, oh, okay, well, that didn't help me get one step closer to overcoming my OCD last time, but I know for sure this next time I'm going to do X in order to help me get that next step closer. And so when you are trying, one of my strategies that I love to use is when I'm coming up to a certain type of exposure that I find really hard, I try to not exactly mimic it the way that I did it last time. So let's say the last time I struggled with maybe picking up a piece of garbage off the floor and throwing it away, and I completely left it there and completely avoided it and walked out of the room. Well, my goal this time then is to do one thing different, even if it's just a centimeter's worth of difference. So maybe that's me walking by the garbage right next to it before I walk out of the room. So if you can try to take it that one extra step, I think you'll still feel a little bit more of an accomplishment. But also there's no need for the guilt and shame. I know easier said than done. And I will say OCD is a guilt-ridden disease. And so we feel this guilt just like we feel anxiety. And I always say it's out of whack. Our fight or flight response gives us these feelings that are not really always reliable. And so you feeling that and then continuing to move forward anyways, and knowing that factually I have this information now to know that next time I can do it a little bit differently.
Absolutely. Next question from Kylie. How do I stop doing compulsions? And how do I handle the distress I feel when I can't perform them?
So great question, Kylie. I really like this one. And it's always a good base for everyone to hear. When we have a compulsion that sometimes is just automatic, it can be really hard for us to even notice it. So I always say, can you tune in to the feelings that you're having? Are you feeling that fight or flight response from like coming up as that anxiousness comes up, so that you can put a pause to it before actively engaging in the compulsion. And the distress that we feel is, again, that fight or flight response that's a little bit out of whack in the moment. And so it's okay to normalize it by saying, you know what, I am struggling with this part of my OCD. Of course, I'm going to feel some distress, especially if I'm trying to do an exposure. But being able to say, okay, the distress of a compulsion or the distress of an exposure, both kind of feel similar depending on the compulsion, but one of them gives you one step closer to freedom. And so trying to teach your brain that you can handle the distress in the middle of living your life is really important and really valuable. So acting on a pause, recognizing my fight or flight's going up, I'm really prone to giving into that compulsion, and then trying to do kind of what I said before. Can you take one step differently instead of automatically going to that compulsion, even if it's just a delay from the compulsion, and trying to engage in your life actively. So I always say, if you delay and you just sit there and you're ruminating, that's not a helpful delay. A delay where, let's say you're at work and you have to answer emails. So make yourself delay and try to fully engage in answering those emails. And if you have to go back to it later, that delay is still one step further than the time before where you just automatically gave into that compulsion.
That's right. And again, I think the important piece here, so Kylie, I love that you brought this up, and I love that Cali said it's such a base for what we should talk about, because it is, and this is such a great piece for us to start with in question. I want to make sure we understand as individuals with OCD that when we do exposures, they shouldn't be brutal forever. So I think that this thought process of like, how do I handle this distress, it's important for us to know that the distress should lessen. If we are doing exposures with response prevention and we're actually approaching our fear, right? The fear should start to have less control on us, less hold on us, right? Those strings or whatever connection gets looser, and eventually they break and the distress goes away. And actually, eventually, it shouldn't even be an exposure. It should just be a task, right? If calling your mom was a trigger, it should just be an enjoyable activity, right? Or something. Sometimes it's something we just need to do, like going to work. It might not be enjoyable always, right? But it's important to recognize that if the distress persists, if the distress gets worse, if we don't feel it's getting better, I want you to stop and say, am I holding on to something? Am I still ritualizing? Am I suppressing? Am I avoiding, right? Because those are the three things that are going to continue to let OCD or fear have control and have this hold on you. And what we should find is that with appropriate ERP, you guys, it should not be miserable. It might be really difficult the first couple times, but it also should be exciting, because it should be an opportunity that, like, while this is a hard challenge, I'm also getting something I want back, right? It's kind of like a workout. It's not always fun, and it should be challenging, right? If we're trying to build muscle or trying to make changes, but it also should be very rewarding, and you should feel good about it and feel proud about it, right? It shouldn't be just like totally miserable all the time, or like you probably should adjust your workouts or do something different. I want us to think the same way about ERP. Next question at 12:09 from Jaber is, could you briefly discuss the checking OCD subtype, constantly checking if doors are locked, emails, texts, on and off switches, etc., and how treatment approaches apply to it?
With checking, similar to other exposures, we're kind of what Liz said earlier, getting at the core, right? So this core fear is either this loss of control or something bad happening because you don't engage in a check. And if we let this core fear rule and dictate, we will become prisoner to the OCD. And so instead, finding that middle zone of, I always say, if we choose in life to try to take a 0% risk, we will be kind of sitting in a room all alone, isolated from the world. It's impossible to live our lives that way. And so finding that middle zone of, okay, I am going to start off with this hierarchy approach and look for freedom in, maybe you start with the thing that's the easiest for you to eliminate checking wise, and then you work your way up. So if the doors are the most difficult thing, or if checking the stove is the most difficult thing, starting with the texts and allowing yourself to at least delay at the very least. So finding the core fear, recognizing if I give into this 100% certainty that I've checked every time, that's a taking away from my ability to live my life and move forward. And so,
yeah. And this is a great question that I want to kind of talk for a second about what I call standard ERP versus ERP plus. So for those of us with OCD, a lot of us will say things like, sometimes treatment feels like this game of whack-a-mole where I'll address one type of OCD and then another type pops up, and I'm constantly just having to like address my symptoms or address what I'm dealing with or current or new triggers. And what I want to push is that that shouldn't be the case with treatment. Treatment is something that when we engage in treatment kind of wholeheartedly or all the way, right, we should experience freedom across the board. And we should see how the concepts of treatment apply to any trigger we have. And that if we lean into those right away, we're able to actually get relief much quicker than if we find ourselves getting caught up in ritualizing and then later it's a bigger thing we have to approach. And so what I want to push here is that, yes, it's critical that we engage in exposures, right? So you still turn the light on and you engage in response prevention. So you prevent your response your OCD wants you to do, which is, so we would just turn the light on and walk away. That's an exposure, and you engage in response prevention. You didn't do a ritual. But what I also want you to do is to be able to accept or acknowledge the fear or the thought that comes along with why you even have that urge to do that, right? Is it, I'm checking my text messages because I want to make sure I didn't say something wrong or that I said something perfectly or people don't, get the wrong perception or people aren't upset with me? Like, what is the fear around the behavior of the checking, right? Whatever that might be. And so let's pretend I'm sending an email to Cali and I have the urge after I send it to go reread it to make sure I didn't have any spelling mistakes because I wouldn't want Cali to think that I don't know how to spell. Not only do I need to send the email, that's the exposure, and I need to engage in response prevention where I don't go read that email, but I also want to lean into the uncertainty that I don't know for sure that my email had no spelling errors and it's perfect, but I'm going to accept the fact that it's good enough and go move on with my life. Because what I'm doing in that moment, that's the plus part of what I say ERP, or as John Grayson and I have done a previous presentation, the ERP plus AU, accepting uncertainty, is I'm acknowledging the fear that even pulled me into having to want to do that ritual. And when we actually allow space or acknowledgement of our fears, it doesn't mean we have to accept them one way or the other, but we just allow them to be there. They can't start to pull us down anymore. And it becomes where later I send emails to Cali and I don't even have the urge to recheck it at all. And I'm still accepting the uncertainty. I don't have to outwardly accept it because it's not a trigger anymore. But when things are triggering, right? When I have patients tell me things like, Liz, sometimes I'm doing really great. And then sometimes I feel like I get pulled back in. And then sometimes I'm great. My response is like, well, then we haven't addressed the core fear. Because when you've addressed the core fear that exists, the urge to ritualize can't pull you back in because you're not afraid of it anymore, right? So like I might have another trigger about an email to someone else, but if I've already accepted that, like across the board, like, oh yeah, I'm good with my emails being, that I do my best and I'm accepting the risk or probability that there might be some errors in them, I'm not going to have the urge to go check it, compared to if I've simply like did an exposure for that one email for Cali, I'm still going to feel like I need to do exposures for every email I send to everyone that's triggering, if that makes sense. 12 your time, Fran. My threat obsession has a great logic. Not obeying it makes me uncomfortable for even years. This way it continues my disease. How do I cope with these obsessions? So I think the question here, Cali, is like when our obsessions are really, really, not only do they feel really real, right? But there might be some logic to them. If I don't give into it, I can be triggered for years. So what do I do? How do I deal with those type of obsessions?
So this one, I think with all OCD, a lot of us have this fear of what if I'm latched onto this forever? I always think that this is something that comes up when you're not a rookie with your OCD anymore. Your OCD gets more creative. And so this fear of, okay, even if I know that this is an OCD thing, my worry is if I don't do this compulsion, I'm still going to be thinking about this years later. And the big piece to remember here is if we focus on the fact that we're still remembering this, right? The next day I wake up, that thought is still there and it's not gone. And is it going to stay for another week or so? It is more likely to stay for another week or so. So when we instead say, okay, that thought is over here and I'm going to try to live in freedom anyways, and I'm nervous, but I'm also going to push forward, then we're more likely to be able to let that thought dwindle. It's like we get the insight, we get the clarity when we stop focusing on it so much. And I had an experience when I ran my big race in 2020 where I got completely re-triggered for about a week. And I hadn't struggled with that much OCD since I was much younger, quite a few years before. And so I remember going to my own provider and thinking, oh my goodness, I am an OCD provider now, and I'm struggling in a way that I was struggling years ago. And now it's like I'm starting all over, when I had already been telling patients this whole time that no, you never start all over. You can't lose the tools that you've already learned. They are innate and they're a part of your toolbox forever, and you're not going to be able to forget them. And so sure enough, that's exactly what she told me when I needed to hear it in that moment, is that Cali, that because my fear was I was going to be latched onto it forever. You're not going to unlearn these things. You've had thoughts like that before. And my argument for that was, well, I've had this thought that I was latched onto for years, and I don't want that to happen again. And she said, Cali, did you even know you had a diagnosis that time? And if I didn't know I had a diagnosis. I didn't have half the tools that I had at this point in time. And so I took a chance and I tried to move forward. And was that thought still there for a few weeks? Yeah, it was. But the more I noticed it going away, was the more I was present and engaging with my life.
That's right.
Even now, that thought comes up and it's not that loud, but it's there. But I know now if I direct my attention to it, it's going to resurface. That's the resurface.
Can you acknowledge, Cali, that if you had tried to solve that thought, right, or engage with the thought, you'd still be more stuck right now?
Absolutely. I would. I was doing that initially when I went to see my provider, and then she gave me that reminder I needed of, Cali, you've got to engage. And if you try to solve, you're just digging that wound deeper. And so I had to trust and try to leave that thought there. And it was terrifying at first, right? My anxiety was up much higher when I first tried to leave that thought versus the second, third week I tried to leave that thought.
That's
Something
right.
that I do that I find really helpful for me is I try to have good experiences when I'm moving forward, because to me, that's evidence that I can continue to live my life. Like, even if it's just 30 seconds of laughing at some kind of joke, I'm able to say, oh, wow, I really genuinely laughed at that joke. And I still had that thought that I was worried was going to ruin my whole life. And then
That's right.
little by little, those experiences get a lot bigger.
And remember, you guys, so what happens is that the more we try to find certainty, so solving gets us stuck, compulsions make us more confused, the more we can acknowledge, or we know for sure, right, that thought sticks more, it has more power, because again, you're responding to it. But what we actually want you to do, whether thoughts feel logical or not, right, all OCD thoughts feel logical in the moment. When we are triggered, it feels real. It feels like we have to solve it. It feels like we need to understand it because we're triggered. That's what a trigger is. That's why if immediately we're like, oh, that makes no sense, the thought wouldn't be a trigger. It would just be a thought, right? It wouldn't stick to begin with. When a thought is sticky, when it's there, when it's triggering, we get sucked in. We have that urge to solve it. And so our treatment is all about uncertainty, which is what Cali just mentioned, which is acknowledging that, like, oh, I have the urge to solve the thought, but I'm going to make the choice not to. And I'm going to make the choice to still live my life, which in and of itself is literally an uncertainty model, right? Because we're choosing to, like, not know for sure if this thought is real, if it's not real, to try to figure it out, to try to solve it, and to choose to move on. What I will push is that if you solve it, try to solve it, it's almost a guarantee that it's going to keep making you uncomfortable. And what I'm going to push is that not obeying your thought. So when you say I've been uncomfortable for years, I'm going to push that. I'm going to bet that's because you've been solving it or trying to solve it here and there. Maybe not all the time, but here and there, which in turn actually allows it to still be present. If y'all are still triggered by thoughts, we haven't fully accepted and leaned into them to be able to move on, right? That doesn't mean we accept worst case, or right, we don't try to get certainty one way or the other. We allow the thought to be there and we still live our life. And that is the biggest piece of treatment, right? Is we don't respond. We don't respond to thoughts and fear and anxiety as if it's dangerous. We acknowledge that it's there. We acknowledge what it's trying to get us to do, and we choose to live our life instead. Next question at 1213 is an uncomfortable memory from over 30 years ago that I'm not sure about. I've spent 6 months trying to remember it and I can't seem to break away. So Cali, if you'll give a little bit of feedback of thoughts around when you have a thought that is a memory that like you don't totally know, but OCD kind of latches on.
Yeah, this feeds off of the last question. It is perfect timing for it. But when we try to remember something from 30 years ago, or not even 30 years ago, 5 years ago, the human brain is not going to be able to remember that correctly. And another really good thing that I experienced with my hit and run OCD, a really helpful technique is if I hit a bump and I replayed that over in my head, my therapist likes to add humor to those types of things. And so she said, well, Cali, by the 30th time you've replayed that bump in your head, you've convinced yourself that you've hit 10 people instead of just that one person. So, and I think that's true for going back on other thoughts, even to a greater extent, because we're trying to remember something from 30 years ago. And with OCD present and the anxiety present, it's only going to do more harm than good. It's only going to fill in those blanks with the scariest thoughts, the worst fears that could possibly come up, which adds more debilitation. So going back to what we said from the other question is we have to leave that there and continue to move forward in life towards values now, because the miserableness that comes up from those thoughts is only going to maximize and increase if we're continuing to replay. OCD likes to fill in the blanks with the wrong information or with information that's not helpful. So moving forward, I always like to use visuals. So I just picture myself, if I'm getting really stuck, lifting my brain up and sitting it on the floor and then kind of continuing on with my day, or that part of my brain.
Yeah, totally. So the next question, I'm going to combine two at once. So one, Chastity asked, is there data on pure O OCD? And then Matt said, I got diagnosed with OCD about a month ago, which explains a lot of my youth. And most of my compulsions are mental. I analyze every thought to see if it's a compulsion or not, and it's very tiring. So I'll answer this quickly, but what I want to say is two things, is that pure O is something we don't really call it as much pure O anymore. And the reason behind that is because it makes a lot of us think that it's purely obsessional, when what we really mean is that, and so people have thought purely obsessional means obsessions and no compulsions. And what we mean is that what pure O kind of meant in the labeling of that is that purely obsessional was the thought process that there actually is obsessions and compulsions, but that even the compulsions are obsessional in the sense that they're mental, right? They're mental rituals or mental compulsions. And what we know is that it's not just obsessions, right? It's obsessions and compulsions. And so there's mental compulsions or mental reviewing, right? A lot of what we've talked about so far actually is mental compulsion. So ruminating, reviewing, trying to solve something, trying to figure something out, mental reassurance, whatever it might be. And so what I want to say about this, Matt and Chastity, is that treatment is the same. Whether you have mental compulsions or external compulsions like a hand wash for contamination, ERP and treatment works the same way. It's just important for us to be able to identify all of the mental rituals we do and to see them as a ritual that feeds the cycle the same way a hand wash would for a compulsion trigger or exposure that somebody had the urge to then wash around. And so the great news is treatment is the same, but yes, Matt, it is very tiring when you're giving into compulsions and when you're finding that your day is spent ritualizing. But what I will also say is that freedom can exist. And when you have freedom, you're not going to feel tired anymore.
Can I add one more quick?
Please.
I also think, Matt, something that you might be hitting on is perfectionism with exposure work, which is like OCD can even latch on to ERP. And so when we're trying to do exposures perfectly, that can actually end up becoming a compulsion. So if you're analyzing every thought to see, is this a compulsion or is this a thought that I don't need to react to, that in itself can become a compulsion. And so instead, I say trying to give yourself a countdown and move forward. And that uncertainty would be, maybe I'm moving forward not knowing that that was a compulsion, or maybe I'm moving forward knowing that that was an exposure. But either way, moving forward in that sense is the exposure.
Yeah. And thinking again, what Cali's describing here is, are we recognizing that core fear, right? So if the core fear is, am I doing treatment perfectly? What we want you to do is not ritualize and lean into the fact that who knows for sure if I'm doing treatment perfectly, I'm still going to choose to move on, right? I'm accepting the uncertainty that exists. Jaybird, this is a great question. I love this. And so Cali, I'm going to throw it to you, but Cali, how would you respond to someone if they say something like, if you know your repeated checking behavior is irrational, why do you keep doing it?
I know there's a bunch of analogies for this too, that you can use that as an example. So now on the spot, I can't think of one of them. Liz, you could jump in and say one. But when you talk to somebody about OCD, I think people should know, well, if I could turn it off, I would. Like, I'm not choosing to struggle and be miserable in this moment. And so giving them some knowledge and insight on that, depending on how comfortable you feel, you get to disclose at your own rate. And so even giving them appropriate resources can be really helpful. Like the Peace of Mind on IOCDF is something that I have as a go-to. So in regards to an analogy, Liz, do you know one?
I think the biggest thing for me is, how can I get them to appropriate education? And so one of the things I'll say to people is like, yeah, like, you're right, that makes no logical sense. And I know it doesn't make sense, but I feel like I have to do it. And the feelings are so strong, and the fears that it elicits are so significant that it pulls me in. And so I will actually say something like, have you ever had a thought that something might have happened to someone you love, or that you're worried about someone you love? And people will often say yes. And I'm like, so what did you do? And they're like, oh, well, I called to check on them, or I, sent them a text to make sure they're okay. And it's like, okay, so what would it have felt like to not send that text or to not call them? Well, that would have been uncomfortable. And why would I do that? Well, that's kind of the same thing, right? It's the same thing as OCD, in the sense that, like, we're checking because we feel like we have to, and we feel like we need to know this and that it's going to make us feel better. But the difference is that sometimes for people without OCD, they're able to say, yeah, but it doesn't, that's not rational. It's not rational. OCD isn't rational, right? But we still get pulled into it, and it makes us feel really rational because the physiological response is really real. So I'll often give examples like that, or I'm trying to think what else. Another example I'll also often give is like, have you ever, before you're going to, if you have a big meeting or like you have a flight the next day and you set your alarm clock, have you ever found yourself double checking it to like make sure you set it and make sure that it's on, or setting a second one? Well, yeah, why do you do that? Well, just to be sure. Yeah, but like, it's irrational. Like, that you've already set the alarm, you don't need to check it, but you're checking it just to double check and to be sure. And you convince yourself that it's rational because you have a big meeting you can't miss. But really, like, that check doesn't serve any extra behavior, right? Any extra, whatever the right word I'm trying to say is, it doesn't give you any extra, like, it doesn't make you more sure, right? It doesn't also, like, it doesn't make clarity. Yeah. Goodness. I was like, I can't think of the word here. But yeah, I think it's really about how can we relate it back to them, but also emphasizing the way our obsessions make us feel, and really making sure they understand that. So one of the analogies that I often will use is I'll say something like, imagine you're in the backyard and you have a 4-year-old daughter, and you're outside with your 4-year-old and you're playing, and you guys are hanging out. There's a pool, and there's, your yard and whatever, and you're just relaxing and enjoying the day. And you hear your phone ringing. And so you run inside to grab your phone, and you come back outside and you can't see your daughter. What happens immediately? And people will talk about, my heart starts racing, my palms start sweating, the hair stands up on the back of my neck. I feel panicked, right? And so I'll say to people, so what do you do? What's the first thing you do? And the typical response, right, is the first thing you do is you go to the pool and you check the pool, because it's the biggest place of danger in that yard, right? And so I check the pool, and she's not in there, and I feel better, but I'm still anxious because I'm worked up and I haven't found her yet. So I'm worried, right? And so I start searching around and I start looking, and then I spot out of the corner of my eye that she's sitting down playing in the sandbox. And I'll say to people, so when you see her sitting in that sandbox, what happens? They talk about this relief, right? That immediately I feel this like exhale, like I can take a deep breath and I can relax because she's safe and she's okay. And sometimes they'll say, I went and hugged her and I just said, I'm so happy you're okay. Mommy was worried about you. Or, whatever it might be. We are asking individuals with OCD to not check the pool. Every time we ask you to not ritualize. That is how significant it feels, and that is how strong it feels. And for those of us who live with OCD, we know that. These risks feel huge. They feel instrumental. They sometimes feel like life or death. They feel they go against what we believe most strongly in and what's most important to us. And of course, in real life, please check the pool immediately, right? Like that's not what we'd ask you to do, but it's important for us to be able to say, that is how real this feels. And that is how, like, we respond with a ritual because it feels so significant, right? It feels so real. And the risk and the danger feels alarming. And so with treatment, though, what we want people to recognize is that we want you to be able to see risks for what they are, right? We want you to be able to recognize there's not even a pool in the backyard. There isn't even something to be afraid of, right? That it's kind of like if your daughter was playing in your playroom and it's baby proofed and you're in the corner on your phone, you know that they're safe, right? Like, we want you to see the risk is really low and you should be willing to let them play or explore because it's healthy for them, not hold them the whole time to make sure nothing happens, right? There's not a pool, there's not real danger. We're going to teach you that, but it takes time because early on it feels like that pool must be where your daughter is, right? And that you have to respond to it. And so the second piece to that, Jaber, is not only do we want to explain how it makes us feel and how strong and significant it is, but I also want us to talk when we're explaining OCD to people. I also want to make sure we're explaining that treatment works and that with appropriate treatment, we actually can get to a place where not only do we not feel like we have to respond and do checking behaviors, but we won't feel like they're as real and we will have more insight, And so I don't want us to have everyone around us just accept, oh, OCD is really hard, so you have to do these rituals all the time. No, like, treatment will allow us to get freedom, but it takes time, right? We can't expect it to be perfect overnight. Gabriella, I am going to point you to some of the webinars that have been done on PANS and PANDAS for more information around OCD that might be caused to autoinflammatory medical conditions. Stacy, you're right. A lot of people don't understand it, even though it's been years. Lola at 1217, what is the difference between OCD and GAD?
So when we generally worry or we have some symptoms of worry, fatigue, continued like sweating palms, feeling dizzy, but we don't have a compulsion, that is more generalized anxiety disorder. We all have, whether we have OCD and anxiety disorder or not, we all have some symptoms of anxiety, right? When we have a big test coming up or maybe a presentation to give in front of a lot of people, we all experience anxiety, but it's when it crosses over to kind of impacting your day negatively, impacting your ability to function, that you might be reaching that disorder point. But then with OCD, as we've discussed, there's a compulsion that follows it, whether it be a mental compulsion of, I need to solve this to make sure that I get clarity or I get certainty, or I have to engage in this physical compulsion. There is something that you do in order to prevent that bad thing from happening or in order to alleviate that feeling of discomfort.
Absolutely. Next question is at 1219 from Hazem. I had it forever. It explains a lot of my failures and struggles. I didn't think it was so bad or the reason behind my failures, but now I know. So, a lot of folks talking about ritualizing and the impact OCD has on their life. And what I want to say is, while this is true, I also want us to recognize that it doesn't have to continue to contribute to our life in a negative way, and that with appropriate treatment, you can live the life you want and have the things that you deserve to have. Patricia at 1220. I do not personally use ICBT as a part of my treatment. I do think it could be a promising addition to ERP potentially. I'm open to anything always being a promising addition, versus necessarily a replacement. I think there's a lot more to be learned and to be said. I'm hoping to do an ICBT training soon to learn a little bit more about it and ways I could potentially integrate it at times if useful for my patients. I do think a lot of these adjunctive interventions are ones that we probably already use in different ways, not even knowing that we use them, but I think I need to learn a lot more about it. And there has been some town halls on ICBT. Katie, this kind of goes at 1224. This kind of goes along with the whack-a-mole analogy. I find that as I'm addressing trauma, one OCD ritual eases up, but then another one flares up. Any suggestions? This is a great question, Katie. And what I'll say is that I want to make sure if you're dealing with PTSD and OCD, that you're addressing them differently. So PTSD, we really should be treating with an evidence-based approach for PTSD, which is cognitive processing therapy or prolonged exposure. And for OCD, we're going to be doing ERP. It's really important we aren't using using an ERP approach for trauma. We don't use uncertainty approaches for trauma because they can be more traumatizing, more triggering. And again, the trauma is rooted in a situation that happened, that we wouldn't want to approach uncertainty for something that was a traumatic event, if that makes sense, because that can make things worse, can make things more difficult and not get you the relief that you deserve. And so you want to make sure you either have a provider who specializes in both or that you're treating both. Because what we can find is that if we're addressing trauma as OCD, it might just kind of morph, right? And so we want you to get relief from both the trauma and OCD symptoms. Jamie at 1225, Cali, will give this one to you. How do you respond to someone who says, oh, I'm also so OCD, when you know they truly don't know what OCD actually is? My 12-year-old was diagnosed this fall, and now I'm talking to teachers, and I hear this often.
Well, one component that I will say is we, as those with OCD diagnosis, at some point we'll all hear this. And we can take that approach of getting really angry and really frustrated. But I think that actually just causes more weight on our shoulders if we're doing that. Or we can take the approach of, okay, this person doesn't have the education. And I can point them in the right direction for this education, where if that is one of your students' teachers, then I think that education is warranted. And so giving them those resources that can fill in those gaps, but also in a kind way, letting them know that OCD is not an adjective. And so we can see that, if there's another diagnosis that I don't specialize in, there's definitely things that I don't know about it because I haven't experienced that. So having that compassion, but also being able to direct those individuals in the right direction is really important. I think that's awesome.
Yeah, 100%. I am IOCDF, myself and others, we've really tagged this headline of OCD is not an adjective. You can go to IOCDF.org and go to the store and buy some shirts and some swag to help support that. I think there's lots of ways we can engage in advocacy. So maybe we can do a post on social media that says OCD is not an adjective and we describe what OCD is. The thing I always try to remember is that someone is saying that because that means they don't understand the severity of the illness. They don't understand the depth of it. And as Cali said, we can look at it as an opportunity to get mad or an opportunity to educate. And my goal is, can we always educate? And so to be able to say something like, I'm sorry to hear, I'm sorry if you're struggling with OCD as well, but I'd love to educate you on the symptoms my child is currently dealing with and what OCD looks like for him. Because as you know, it can look very different in everyone. And to give them resources, to give them tools, and maybe with appropriate resources and tools, as they start to understand what OCD is, they're going to say, oh, I don't have OCD and I shouldn't be saying it like that. But I think it's a great opportunity to educate, but you will hear it and we will get frustrated. But again, the fact that people even know what OCD is as an acronym is actually progress, even if they know it in the wrong way. Sorry, we have a lot, so I'm trying to get through a lot of different things. So Catherine at 1225, I have chronic fatigue syndrome and I'm going to visit my mother who needs assistance with cooking, running errands. If I get set back and I'm having to spend most of the day lying down, I get caught up in anxiety and obsessing how I need to recover so I can help her out. I have body sensations of severe fatigue and my legs feel like they're buzzing. I find I get very stuck in anxiety and worry about obsessing, and all that just feeds me getting set back more. So I think this is a great question, Catherine, as you bring in when there's a medical concern and medical things going on, but then OCD and anxiety also attaches and plays a role in it. So Cali, anything to add?
Well, I think finding the balance there is going to be important, right? So if you're noticing that your doctor said something very specific for you to do, it's good to carry that out. But if you're needing to go back and ask questions like that repetitively, or if you're replaying conversations you've had with them, or you're analyzing the symptoms, something I find, the day before a big race, when my anxiety is much higher, if my ankle is just a little bit, tight or sore, I am going to convince myself that ankle is really hurting because all of my attention is drawn to that ankle. And so trying to give yourself that balance of, okay, this doesn't feel very good, but the more I'm going to focus on it, if my doctor already gave me my recommendations and I know how to carry this out, the more I'm going to notice those sensations, the more I'm going to get anxious. And so I think the best thing in that scenario is finding the balance between taking care of yourself, but also being aware of when that becomes a compulsion of replaying or looking up extra information to try to find clarity, because we maybe can never get enough of that clarity.
That's right. Yeah, 100%. Next question from Lola at 1227. Can extreme Googling for hours with medical symptoms and conditions be OCD or an anxiety disorder?
Love this question. Absolutely. So when we ask ourselves, am I trying to find an answer or certainty for this thing, then absolutely looking at the core fear, then that would be an OCD compulsion, right? You're trying to alleviate the anxiety you feel about the uncertainty by Googling, or there's other ways you can struggle with this form of health anxiety too, by going to the doctor over and over, by calling a doctor, by getting opinions from other loved ones. The reality is, though, when you're Googling online, you will most likely find one symptom that can meet something that you struggled with, and that's only going to increase the anxiety more. And so giving yourself that room as a exposure that we've had people do a lot with health anxiety is limiting the Googling, right? Or trying not to Google at all and just going to your yearly, or however often you go to your general practitioner to get that advice elsewhere. But yes, very much a common OCD type of tendency behavior.
100%. What about at 1229? What about if I feel like I could have made an unsafe mistake at work and I want to keep going to go check? It's been a week, but how do I stop worrying?
We've touched on this one too, right? If we, I think we said this last week, and it really stuck with me. Compulsion equals confusion. So if we're continuing to go back and in our head, not actually physically, but we're going back, we're not actually living out the exposure. You're just doing another form of a compulsion over the checking. So mental rituals still equal compulsions, which is only going to make that thing hover a bit more. Trying to be more engaged in your activity that you're doing for work with that thought kind of buzzing around like a fly instead of an elephant will help give you more clarity to move forward, more peace from that anxiety. So just being aware of those mental compulsions can help you to fight the OCD in a more appropriate way.
100%. I love that. A bee instead of an elephant. I think that's a great analogy. But yeah, again, remembering, right? Like if there is something that is truly dangerous or something we truly need to address or understand, like, yeah, we might want to go understand that and address it once, right? Like that would be important to figure out. And it's kind of like if Cali were to tell me about a medical concern she's ruminating on, and I said, have you gone to the doctor? And she's like, no, I might say, okay, well, going to the doctor once, getting medically evaluated, making sure it's not something medically to be worried about. That makes sense. I would encourage that. But after that, I'd want her to follow the recommendations of her doctor and accept that as good enough and move on, right? And to not do rituals around, do I know for sure? How do I know they didn't miss something? How do I know this is the right thing? Because we will get more stuck, right? So again, it's this kind of piece where sometimes there is things that happened or there are concerns, and like one check makes sense, right? And it's useful, it's helpful, it's fine. It's not really a ritual in that moment. But when it's multiple, when it's above the norm, when it's something someone else wouldn't be doing, that's when we can start to say, okay, this sounds more like rituals that we need to reduce. I love, Lana, the thought of using computer analogies, like it's a glitch in the system and that sort of thing. Next question with Ro at 1233. My name is Rohit Row. I suffer from hit and run OCD, and I keep on ruminating about my past driving experiences to see whether I hurt any pedestrian or not. I'm not able to get out of the loop. And Cali, I know you talked a little bit. I know you and I both had hit and run OCD, but talk a little bit about this and how we can get out of the loop and what that actually looks like.
Especially if we go back on moments that happened years before or weeks before, we are going to add extra information to that compulsion. So it's only really making the compulsion harder. When we do something like maybe don't go back, but look in the rearview mirror, that is still giving the OCD some of what it wants. And so we are trying to drive forward something that I do personally, because I still have some hit and run tendencies that pop up every once in a while, is I find myself evaluating how a bump felt, right? A bump in the road felt. Did that feel like a person? Did that feel like X, Y, or Z? Again, another compulsion, right? We're wanting clarity about how that felt. So something that helps me get out of that is waiting for the next bump. And that might not be helpful for everyone, but when I wait for the next bump, then I'm able to kind of let go of that last bump and focus on that one. And for me, that's enough of education to know, oh, I recognize this pattern. This is an OCD thing, and I've got to keep moving forward. So ruminating about the past, kind of just going back to that compulsion equals confusion piece, and driving, focusing on the present, even maybe doing some like, okay, what can I spot out here that is unrelated to the bumps that I'm hitting in the road? Okay, I see these trees, all these other things, maybe listening to a podcast. If you're at a place where you can do that, something that helps get you back in the present moment instead of ruminating, because that's only going to add fuel to the fire.
That's right. And a lot of other thoughts and comments that have been given. And, because of the time, I don't think we'll get into pre-submitted questions because we didn't get time to, but I just wanted to say thank you. Thank you, Cali, for joining the past couple weeks. And thank you all for showing up and for participating, because I want to recognize and acknowledge that for many of you with OCD right now, showing up to this live stream is difficult. It's triggering, but it's also evidence that you want to understand how to better work on yourself and your symptoms so that you can achieve freedom. Cali, in the last few minutes, one of the things I want to touch on for a second, I'd love to hear your thoughts, is I'd love to hear a little bit about your treatment recovery, and if you had an aha moment, or for you, what were some of the differences between when treatment started to stick versus like it was a concept that you could do in moments or sporadically?
I would say I still have aha moments, even to this day. Something that I found myself doing often was telling patients what I knew was true, and that like OCD symptoms will resurface, but they don't ever have to be as bad as they once were. And so then when I had my own aha moment that I spoke about recently was after the Olympic trials, and I had that really big trigger, and I found myself feeling like, wait, is everything that I said not true? Like, am I going back to where I was, even though I have these tools? And when I got back from being away for this race, I re-implemented the tools and I came back way faster than before. So that is a huge aha moment for me, that I will never lose the strategies that I've learned. And every time I respond to OCD a little bit differently, I feel is an aha moment. That when my provider told me, Cali, the more you replay this, the more extra information that you're going to add to it, I was terrified that I was going to be latched onto this thought for many, many years, like I was the previous one. And the fact that she said, can you just trust me a little bit and just let that thought be and try to move forward? And if it comes up, acknowledge it, but then move forward again. And it was so hard for me to let go of that, kind of like letting go of someone falling, right? Just didn't want to pry my hands off of it. But once I did, I started to see that glimpse of freedom. And so knowing that I was being able to be refueled and I trusted that part of the process helps me see any trigger that comes my way in the future, no matter how sticky or terrifying it feels when it comes to how long it's going to stick around. I've been there before and I've experienced that, and I didn't always respond in the right way, but I guarantee I have that extra tools I need now to respond differently that next time. So
that's right. And the thing I'll push that, maybe we would agree with too, is we practice this every day, whether it's OCD or not. There's so many ways that I was just thinking about my own life is like, how do we not respond with urgency, right? How do we see situations for what they are? How do we not be reactive? And to know that when we aren't reactive, things is so much more is accomplished, right? In anything, in any situation in life. And I just love that for OCD, one of the things we can acknowledge is, while we wish we didn't have OCD, the treatment that's for OCD applies to so much of our life. It doesn't just apply to OCD symptoms, right? The ability to be able to not respond to fear, to not respond to anxiety, that is an opportunity for us to really use it across the board and be able to be present everywhere, right? Not just OCD, and to see like where, gosh, this is like that response and that anxiety isn't useful across the board. And I love that about the treatment. One of the other things I'll say, Cali, is that I think that every day when we learn and every day when we get older, the more we can understand the why and really understand the mechanisms behind what OCD is trying to do, right? It's tricking us, it's trying to pull us in. And the more we can see it as this trick and what it's trying to do, and that if we respond to it, it wins, right? It's won that game for the day, and it's going to get bigger, the more we're able to start to catch it before we respond, right? So to be able to be like, here's OCD again. And I know if I respond this way, it gets bigger. If I respond that way, it gets smaller. And so what choice am I going to make, right? We're able to start to see the choices. When we're early in treatment, it's all automatic. It doesn't feel like we can break it down, right? It's kind of like when someone with panic disorder says, well, I just have random panic attacks. Like, no, there's usually triggers and there's things, but we need to really slow down and break it down. And so the more we can slow down and the more we can acknowledge, as Cali said, even though sometimes it pulls us back, that the treatment stays the same. Sure, it might look a little bit different, or sure, we might need some extra push to apply it sometimes, or we need extra accountability. But really the concept of treatment is how can we quit responding to fear and anxiety and instead respond to values in life? And if we choose to live our life and live by our values, then the pull to live by our fear goes away. And what I can promise you is when you release living by your fears, freedom comes next. And that is the greatest reward we can ask for. So thank y'all for joining. Thank you for coming. I can't wait to see y'all on continued live streams. We won't be here next week on Tuesday doing Ask the Experts because Kyle and Dr. Bramowitz will be here to do the research roundtable next Tuesday, but I will see you all in a couple weeks. Cali, I'll let you wrap up, but thank you for joining. Thank you for your expertise, and I can't wait to have you on many more.
Yes, loved seeing the comments. Thank you all so much. I'm just going to end with one of my favorite quotes that I constantly remind myself of, and it's a Brene Brown quote, and it says, I don't know exact words, but paraphrasing, your hurts along the way that you grow and overcome are going to be someone else's lifeline. So survival guide, someone else's survival guide.
That's it. That's totally true. And last question I have to answer because I see it and I can't, is Christine at 1253. Absolutely, Christine, I want you to work on seeing an OCD specialist. So while medication can help, there absolutely also needs to be behavioral interventions for your daughter. If she's not eating, of course, you want to make sure that there's medical interventions first and that you can get her eating and that you get her medically stable. And then we want to make sure you're addressing it behaviorally as well, because medication alone isn't going to address these fears that are impacting the way she lives and functions. So keep that in mind. Mohammed, please continue to check out live streams as we talk about all sorts of treatment, all sorts of approaches, and you can find those on IOCDF.org or, of course, on our YouTube channel. Thank you all. See you in a couple weeks.